Hi friends, once again welcome back to the Nurse channel. So as you all know that we have started a series named AIIMS NORCET and the JIPMER series for the preparation for the upcoming nursing officer examinations. And you all know that the notification have come for the JIPMER examination, and I hope you all have applied. So keeping these two exams in mind, and apart from this, the other ICT-IMST exam also we are awaiting. So keeping these exams in mind, we started a series, and whoever didn't watch our old videos, kindly watch those videos. And I request everyone who are watching this video to watch the video without skipping. And if you are not subscribed yet, kindly subscribe and support. So straight away we will move on to the another 15 important questions which are taken from different areas of our nursing subjects. So we will start this session, and straight away we'll move on to the questions. So we will see the very first question in our series. The first question is in the screen right now. So the question is from the cardiology. It's a very simple question. The question is, the principal effect of nitroglycerin is. Question is the principal effect of nitroglycerin. So the options are: option number A, antispasmodic effect on the pericardium. Then option number B, causing an increased myocardial oxygen demand. Option number C, vasodilation of peripheral vasculature. And option number D, improved conductivity in the myocardium. So what is the principal effect of nitroglycerin? And you know why when nitroglycerin will be given, and what is the route of administration, all those things. So just think about that and answer the question. So the answer for this question is option number C, that is vasodilation of peripheral vasculature. Okay, so the other options are absolutely wrong, that we will see in the explanation. So we know that nitroglycerin, it produces the peripheral vasodilation, which reduces the myocardial oxygen consumption and demand. Okay, so you can omit some options I have already given, that it is a peripheral vasodilatory effect and it reduces the myocardial oxygen demand. Myocardial oxygen consumption also will be reduced, and it is a vasodilatory drug which is used primarily to provide relief from anginal chest pain. Okay, so this medicine will be given as an emergency medicine, and it will be administered sublingually for an easy absorption, and it is have a sudden vasodilatory effect will be there. Okay, so that is a answer for the first question. So we will move on to the second question in our series. So this is from the lung sounds, and the question is, which sounds can be heard during inspiration which are caused by sudden opening of the alveoli? So the question you should read very carefully. Which sounds can be heard during inspiration which are caused by sudden opening of the alveoli? So the two key points in this question are, the first one is inspiration and sudden opening of the alveoli. So the options for you are: the first option is wheeze, option number B, crackles, option number C, stridor, option number D, rhonchi. So I have told you the two key points, that is, one is the inspiration. The sound is heard only during inspiration, and it is caused as a result of sudden opening of the alveoli. So what is the answer? So the answer is option number B, that is crackles. Okay, so we will have a small explanation regarding this question. So the basilar crackles are usually heard during the inspiration and are caused by sudden opening of the alveoli. Okay, so it is heard during inspiration and it is caused by the sudden opening of the alveoli. And basilar crackles are a bubbling or crackling sound originating from the base of the lungs. Okay, so then what about the other sounds? The first option was the wheeze. So we know that wheeze is a high pitched sound produced by the narrowed airways. Okay, and they are most often heard when the person is exhaling, that is during the phase of expiration, not inspiration. Okay, then another option was the stridor. So stridor also is a wheeze like sound which is heard when a person breathes, and it is due to the blockade of the airflow in the trachea or in the back of the throat, that is stridor. And the another option was the rhonchi. So what is the rhonchi? Rhonchi sounds resembles that of snoring. Okay, so the sound resembles that of snoring, and they occur when the airway is blocked or the airflow becomes rough throughout the large airways. Okay, so these are the difference between these lung sounds. The answer for our question is crackles. Okay, so now we will move on to the third question in our series. The third question. So the question is regarding the burns, and the question is, redness with clear blisters can be seen in which type of burns? So question is very simple and it is very direct. redness with clear blisters can be seen in which type of burns? And the options are option number A, superficial first degree burns. Then option number B, superficial partial thickness burns or the second degree burns. Then option number C, deep partial thickness or the second degree burns. Then option number D, full thickness, which belongs to the third degree burns. So we'll be confused between these two options, that is superficial partial thickness and deep partial thickness. Superficial partial thickness and deep partial thickness are coming under the second degree wounds, okay, second degree burns. So that's why I have mentioned that it is an additional information also, okay. So in exam, you may not get these bracket portion, okay. So what is the answer for the question what we have asked now? Clear blisters can be seen in which type of burns? So what is the answer? Answer is option number B, that is superficial partial thickness burns second degree. Okay, so we will have the explanation for this question with the help of some pictures. So the first picture, you can see the corner of the screen right now. This is the superficial first degree burns or the superficial burns, and here the part involved, the skin part involved is only epidermis, not dermis, only epidermis, and the appearance will be like it is red without blisters. So in the picture you can see the color of the body, that it is reddish without the presence of any blisters. Okay, so that is a superficial or first degree burns. Then comes the second one, that is a superficial partial thickness or the second degree. Okay, this word is very important, partial thickness, and you can see a picture also. Here we can see the superficial dermis. Okay, so here after the epidermis, dermis also is getting affected, but only the superficial part. So superficial dermis or the papillary region is getting affected in superficial partial thickness burns, and there will be a redness with clear blisters. So we can see the clear blister here. So if there is a presence of clear redness, then that will fall under the superficial partial thickness burns second degree, which affects the superficial dermis, that is in the papillary region. Okay, so in the other option, then deep partial thickness. Deep partial thickness means that also belongs to the second degree burns, but here the deep partial thickness means the deep reticular dermis is getting affected in this type of burns. Okay, deep dermis is affecting, that is reticular. Okay, and the appearance will be yellowish or white. Okay, so you can see the burn area will be yellowish or white in appearance and may be blistering. Okay, sometimes blister will be there and sometimes the blister may get broke. Okay, so that is a deep partial thickness which affects the deep dermis. Okay, then comes the next thickness of wounds, that is a full thickness burn or otherwise known as the third degree, and it extends through the entire dermis. Okay, so here the total dermis will be affected and the appearance will be, the wound will be very stiff and it will be white or brown in color. Okay, white or brown in color. And the last one is the fourth degree burns, otherwise known as the we can see scars. Okay, that I will explain. So the fourth degree burns, it extends through the entire skin and into the underlying fat, muscles and bone, as you can see in the picture, and the appearance will be black and it will be charred with scar. Okay, so scar formation will be there, that is a rough tough tissue will be there, and this is a fourth degree burns. Okay, so I think with this question you are getting information regarding different types and degrees of burns. Okay, I think that is clear for you now. Now we will move on to the next question, that is the fourth question. So this is from the obstetrics and gynecology. The question is, which structure provides the major support to the uterus and cervix? Okay, so question you should read very carefully. Which structure provides the major support to the uterus and the cervix? So you know about the several ligaments of the uterus and the cervix. So the options are option number A, round ligaments, option number B, broad ligaments, option number C, cardinal ligaments, and option number D, uterosacral ligaments. So what is the answer? So here the key point in this question is the major support to the uterus is given by which ligament? That is the question. So what is the answer? So answer is option number C, that is cardinal ligaments. Okay, option number C, cardinal ligament. Okay, so we will have a small explanation regarding this question. So the cardinal ligaments, otherwise known as the Mackenrodt's ligament or the lateral cervical ligament or the transverse cervical ligament. So it is a major ligament of the uterus, and it is located at the base of the broad ligament of the uterus, and we have two pairs. We have a pair of cardinal ligaments. That means we have two cardinal ligaments in a female human body. Okay, so that's all regarding the cardinal ligament, and this is a major ligament that supports the uterus and the cervix. Okay, otherwise known as the Mackenrodt's ligament, or the lateral ligament, or the cervical ligament, or the transverse cervical ligament. Okay, so I think that is clear for you. We will see about the other options also. You know that what is the round ligament. So the round ligament of the uterus, it originates at the uterine cornu of the uterus, and it blend with the tissues of the mons pubis and labia majora. Okay, so this ligament will connect with the uterus with the tissues of the mons pubis and the labia majora. So what about the broad ligament? So the broad ligament is the peritoneal fold which around the round ligament, and it is a parametrical connective tissue, arteries and veins, lymphatics and nerves. Okay, so that is the broad ligament. So like the arteries, veins, lymphatics and the nerves are getting passed through this broad ligament, which is a peritoneal fold. Okay, then another ligament was the already we have explained regarding the cardinal ligament. Okay, so now we will move on to the fifth question, the very important question in our series. So the question is, poorly controlled hyperparathyroidism may cause. So you should read the questions very carefully. Poorly controlled hyperparathyroidism. So the options are, first one is low calcium, option number B high calcium, option number C high phosphorus, option number D low calcitrol. So what is the answer? So just to think about what is a hyperparathyroidism, what is parathormone, and what is the role of parathormone in our body. Those things you can remember, and you can answer this question very easily. So what is the answer? So the answer for this question is option number B, that is high calcium. So okay, high calcium. So you know that the calcium control in our body is done with the help of this parathyroid gland. That how I will explain this with the help of this picture. So we know that we have 4 parathyroid glands which are situated in the thyroid gland. Okay, in the corners of the thyroid gland we have 4 parathyroid glands. Okay, so the parathyroid gland secretes the parathormone, so it helps in regulations of calcium in the blood. Okay, so how it is that you know that it will absorb calcium from the bone. It will take calcium from the bones, and it will be taken up to the into the blood, and thus the serum calcium will be increased, and it helps in the absorption of calcium. More calcium will be absorbed from the tubules of the kidney in the absorption phase, and thus the calcium level will be increased, and it stimulates the kidney to secrete active form of vitamin D, otherwise known as a calcitrol, and this calcitrol in turn will helps in the increased intestinal absorption of the calcium. Okay, so parathormone will help in the regulating the calcium level of the blood through bone, kidneys and intestine. Okay, so what will happen if there is an increased parathormone secretion, that is a hyperparathyroidism? What will happen is there will be increased calcium level in the blood, there will be increased absorption of calcium from the bone, from the kidney and from the intestine. So there will be increased calcium uptake, and there will be hypercalcemia will be there. And what happens with the phosphorus? So this parathormone have an effect on the phosphorus, like the absorption of phosphorus from the kidneys will be reduced, okay, with the presence of parathormone. So what will happen is, if there is a parathyroid hormone increase, there will be reduced absorption of phosphorus through the tubules into the blood, and there will be hypophosphatemia. Okay, so this calcium and phosphorus are always inversely proportional. Whenever there is a hypercalcemia, there will be hypophosphatemia. Okay, hypercalcemia and hypophosphatemia. And in the option I have explained about the calcitrol. So what is a calcitrol? Calcitrol is the active form of vitamin D, and parathormone will help in the conversion of that active form of vitamin D, that is a calcitrol, and this calcitrol will help in the absorption of calcium from the intestine. Okay, so I think that is clear for you with the help of this diagram. So we'll have a small note on this parathormone also. So poorly controlled hyperparathyroidism may cause an elevated serum calcium level, that is hypercalcemia, and thus in turn may diminish the calcium stores in the bone, causing the bone demineralization and setting the stage for the pathological fracture and risk for injury. Okay, so this is you can expect some application level from question also from this area. Okay, so I think the parathormone and the calcium maintenance, I think you got an idea. Okay, so now we will move on to the next question in our series, that is the 6th question, that is from the addiction medicine psychiatry. The question is, drug of choice in opioid addiction is. So which is the drug of choice in opioid addiction? Question is very direct, so don't be confused with the options. The options are, the first option is naloxone, the second option is diazepam, the third option is methadone, and the final option is lorazepam. So which is the drug of choice in opioid addiction? So what is the answer? So the answer here is methadone. Okay, so you will be confused with naloxone and methadone. So opioid overdose, if there is an opioid overdose or the morphine overdose, naloxone is the antidote to revert the morphine effect. So that is for the overdose, but the drug of choice for the addiction management is the methadone. Okay, so the other options you can see, the diazepam and lorazepam, all these are benzodiazepines, and these are the drug of choice for the alcohol addiction, not for the opioid addiction. Okay, so I think it is clear. Naloxone is for the opioid overdose, diazepam and lorazepam belongs to the benzodiazepine groups, which are for the alcohol dependence, and methadone and other drugs that I will explain in the explanation session. The most common medications which are used in the treatment of opioid addiction include methadone, buprenorphine, and naltrexone. So not naloxone, naltrexone. So all these drugs are used for the opioid addiction. In that, methadone is the most important drug, and in clinical settings we can see the use of buprenorphine and naltrexone also. Okay, so what is an methadone? Methadone, it is a synthetic opioid agonist, and it can be used in a daily basis to relieve craving and to remove the withdrawal symptoms. Okay, so I think this question also is clear for you. Methadone for opioid dependence addiction management. Okay, so now we will move on to the next question in our series, that is from the stroke management, and the question is, what is the time frame for administering TPA? So what is TPA? That is the tissue plasminogen activator, and for what condition and all we are giving, that you know very well, that is for the ischemic stroke. So what is the time frame for the administration of TPA? That is a question, and the options are, first option number A, within 24 hours, option number B, within 12 hours, option number C, within 6 hours, and option number D, within 3 hours. So what is the answer for the question? What is the time frame for administering TPA? So you know that it is a very important, and it's a frequently asked question also, and the answer for this question is within 3 hours of the development of stroke we have to give the tissue plasminogen activator. So IV tissue plasminogen activator should be administered to all eligible acute ischemic stroke patients within 3 hours of last known normal. Okay, and in some other studies they have mentioned like up to 4.5 hours we can give, 4.5 hours, up to 4.5 hours we can use IV TPA. So how this TPA will act, that we can explain with the help of this diagram. So if you are administering the TPA, it attaches to the fibrin on the clot surface. So how it will attach is, it will activate the plasminogen, and from the plasminogen, plasmin will be activated, and this plasmin will dissolve the fibrin, and it will result in the formation of fibrin degradation products. So in the picture we can see the thrombus, it is very tight thing. Okay, so this will block further blood flow. So by administering TPA, it will attach to the plasminogen, and these plasminogens will convert into activate the plasmin, and this plasmin will dissolve the fibrin. So here the thrombus is more, here the it will dissolve the fibrin, and it will result in the fibrin degradation product. Okay, so this is a management, this is the action. Okay, so the plasmin is subsequently cleaved from the plasminogen affiliated with the fibrin, and the plasmin breaks up the molecules of the fibrin, and the clot get dissolved. Okay, so this is the action of TPA, or the tissue plasminogen activator. So I think this also is clear for you. Now we will move on to the 8th question in our series, and this is a picture based question, and the picture, and your task is to identify the disease, and the picture is here in your screen right now. You have to identify the disease. So it's a type of skin rash. So what is the peculiarity of this skin rash? That's the question. So the options for you are, option number A, measles, option number B, German measles, option number C, SLE, and option number D, chickenpox. So what is the answer for this question? Identify the disease. So the answer is, you know that is SLE, otherwise known as the systemic lupus erythematosus, and the peculiarity of the rashes that we will explain in the session. So we can see a picture here. We can see a rash which happens symmetrically, which is happening in SLE, and we can see a red or purplish rash that extends from the bridge of the nose over to the cheeks. Okay, bridge of the nose over to the cheeks in a shape that resembles that of a butterfly. So butterfly shaped rash that extends from the base of the neck, okay, from the nose over to the cheeks, and it will be symmetrical. So this is the characteristics of the rash, that is a butterfly shaped rash, which can be seen in SLE or systemic lupus erythematosus. So what about the other disease rashes? So this is the peculiar rash that we can see in measles, and the characteristics is it is classically described as a generalized red maculopapular rash. Okay, maculopapular rash can be seen that begins several days after the fever starts. That is measles. Then what about the German measles? So in the German measles, the area affected is similar to that of the measles, but the rash is less intensely red. So you can see the difference. I will give you the old picture. Here it will be a red macular papular, generalized red macular papular, but in German measles that intensity of the red will be little less. Okay. Then what about the other condition, that is chickenpox? So in the chickenpox or the varicella, you can see the classical symptom of the chickenpox is a rash that turns into itchy fluid filled blisters. You can see blisters here that eventually turn into scabs. Okay, so that is the peculiarity of the chickenpox rash. So with this question you are getting a picture based information of the different types of the rashes which can be seen in SLE, chickenpox, measles and German measles. Okay, so I think this question is very helpful for you. Now we will move on to the next question, that is the 9th question in our series, and the question is, dash is not a medication of choice to treat pain in acute pancreatitis. So the question is very simple. Dash is not a medication of choice to treat pain in acute pancreatitis. So here the key point in this question is not a medication and acute pancreatitis. Okay, so the options for you are, the first one option is niperidine, the second option is morphine, the third option is acetaminophen, and the final option is fentanyl. So which should not be used for pain management in acute pancreatitis? That is a question for you. So the answer? So the answer for this question is morphine. So why, that we will explain in this explanation session. So miperidine, we are using miperidine is a drug of choice, and fentanyl also can be used, and acetaminophen also can be used as a first line pain management medicine. So miperidine rather than the morphine sulfate is the medication of choice to treat pain, because morphine sulfate can cause the spasms in the sphincter of Oddi. So sphincter of Oddi and all I have already I am not going to explain in detail, that you can refer or we can see our old videos, we have already explained. So there will be further sphincter of Oddi spasms will be there, which can aggravate the pain for the patient. So that's why the morphine sulfate is not preferred as a drug of choice, and we will be giving miperidine. And fentanyl also being increasingly used because of its better safety profile. And acetaminophen already I have explained, for the minimal pain or a less severe pain, we can use acetaminophen also as a medicine for the pain management in acute pancreatitis. Okay, so this is also a frequently asked important question. I think you understood this question. Okay, now we will move on to the 10th question in our series. So this is also a very important question. The question is, patient with a diagnosis of chronic gastritis is at risk for which vitamin deficiency? So the question is very simple, direct question. Patient with a diagnosis of chronic gastritis is at risk for which vitamin deficiency? And the options are, option number A, vitamin A, option number B, vitamin B12, option number C, vitamin C, and option number D, vitamin E. So gastritis and is related to which vitamin? So just think about the physiology, you can answer this question very easily, and obviously the answer for this question is option number B, that is vitamin B12. So we will see the physiology. So we know that chronic gastritis causes the deterioration and atrophy of the lining of the stomach, which leads to the loss of function of the parietal cells. Okay, so the sources of the intrinsic factor is lost, which results in the inability to absorb vitamin B12. This leads to the development of pernicious anemia. Okay, so you are getting a bunch of information from this paragraph. So chronic gastritis, which causes a what will happen is there will be deterioration and atrophy of the parietal cells. Okay, why parietal cells are important? Parietal cells are important in the production of these intrinsic factors. Intrinsic factors can be seen in the parietal cells, and this intrinsic factor is very much important for the absorption of vitamin B12. So in chronic gastritis, the atrophy of this intrinsic factor will happen. Atrophy of parietal cells will happen, that will cause the decreased vitamin B12 absorption, and the patient can develop pernicious anemia. And a small note regarding the intrinsic factor, or otherwise known as the cobalamin binding intrinsic factor, and also known as the gastric intrinsic factor. It is a glycoprotein which is produced by the parietal cells or the chief cells of the stomach, and it is necessary for the absorption of vitamin B12. Okay, so I think you are getting a lot of information out of this question. Okay, so I think that question also is clear for you. Now we will move on to the 11th question. The 11th question in our series, that is from the nephrology. The question is, which health history is important in patients with glomerulonephritis? So it is an application level question. Question is, which health history is important in patients with glomerulonephritis? So the options for you are history of renal calculi, option number B, history of renal trauma, option number C, history of recent sore throat, and option number D, family history of acute glomerulonephritis. So which health history is more important for glomerulonephritis? So the answer for our question is option number C, that is a recent sore throat. Why recent sore throat? That we will have an explanation in the explanation session. So you know that the most common form of acute glomerulonephritis is caused by group A beta hemolytic streptococcal infection elsewhere in the body. Okay, so a sore throat which can be caused by a group A beta hemolytic streptococcal infection can result in the development of acute glomerulonephritis. So you know about post-streptococcal glomerulonephritis, otherwise known as the PSG, and this is a type of glomerulonephritis which results from a bacterial infection that causes rapid deterioration of the kidney function due to an inflammatory response following the streptococcal infection. Okay, so that's why the history regarding a recent infection like sore throat is very important in diagnosing glomerulonephritis. Okay, so post-streptococcal glomerulonephritis is also a type of glomerulonephritis. Okay, I think that is clear for you now. So now we will move on to the next question, that is the 12th question in our series, and this is from respiratory disease condition. Question is, anteroposterior diameter of the chest will be increased in which condition? Okay, so the question is, anteroposterior diameter of the chest will be increased in which condition? And the options for you are chronic obstructive bronchitis, option number B, emphysema, option number C, bronchial asthma, option number D, bronchial asthma and bronchitis. So what is the answer? Bronchitis, emphysema, bronchial asthma and bronchitis. So what is the answer for this question? Anteroposterior diameter. Just think about the another name for the increased anteroposterior diameter. You can answer this question very easily. So the answer for this question is option number B, that is emphysema. So you know that in emphysema what is happening is there will be hyperinflation of the alveoli and flattening of the diaphragm. So diaphragm will be flattened and there will be hyperinflation of the alveoli, which in turn leads to increased anteroposterior diameter, which is referred to as barrel chest. Okay, so every time you will be getting question like barrel chest condition can be seen in which disease condition. So you should understand what is a barrel chest. Barrel chest means there will be increased anteroposterior diameter of the chest, which can occur as a result of the hyperinflation of the alveoli and flattening of the diaphragm, which can be seen in emphysema and not in other conditions. Okay, so barrel chest, emphysema. I think this is also clear for you now. Now we will move on to the 13th question in our series. So this is from endocrinology. So the question is, which among the following you can expect in a client with hypothyroidism? So here the question is regarding the clinical manifestations of hypothyroidism. So the options for you are increased appetite and weight loss. Option number B, puffiness of the face and weight of the face and hands. Then option number C, nervousness and tremors, and option number D, thyroid gland swelling. So which you can expect, which among this can be expected in hypothyroidism? So regarding hypothyroidism and TSH values, already we have explained in our old videos. Whoever didn't watch that videos, you can go through that and then you will get an idea about TSH level and hyper and hypothyroidism. Okay. So what is the question for the present question? What is the answer? Answer for the present question, and the option number B, puffiness of the face and hands, is the answer for the question. So we know that hypothyroidism, or the severe form we called it as mixed edema, it causes a facial puffiness, extremity edema and weight gain. There will be weight gain in hypothyroidism. So don't be confused. Weight gain in hypothyroidism, which and signs and symptoms of the hyperthyroidism, that means the Graves' disease, severe form Graves' disease, it include an increased appetite. There will be weight loss, nervousness, tremors and thyroid gland enlargement, that is the goiter. Goiter can be seen in hyperthyroidism. Okay, so you can omit all other options if you know the signs and symptoms of hypothyroidism. Okay, so I think that also is clear for you now. So this is very, very important. In some or the other ways we can expect question from this area. Okay, now we will move on to the second last question in our series, and the question is, during the first 24 hours after the thrombolytic therapy, the primary goal is to control dash. So the question is, the patient has undergone the thrombolytic therapy. So the first 24 hours, what we have to control? Okay, what is the goal of treatment? So the options are, we have to control the patient's pulse, option B, respiration, option C, blood pressure, and option D, temperature. So which we have to monitor and record and maintain. So what is the answer? Post thrombolytic therapy. So the answer is option number C, that is blood pressure. Blood pressure is very, very important. So why? Means controlling the blood pressure is critical, because an intracerebral hemorrhage is the major adverse effect of the thrombolytic therapy. Okay, so if BP increase, there will be chances of further hemorrhage and patient can go to another stroke. Okay, so controlling blood pressure is very, very important. Okay, so other vital signs are also should be monitored, like temperature, pulse, respiration, everything should be monitored, but the priority is for the managing the blood pressure. Okay, so I think that question also is clear for you. Now we will move on to the very last question in our series, and this is also very, very important question, and the question is, dash is an involuntary loss of a small amount of urine due to sudden increased intra-abdominal pressure. So this question is regarding the urinary incontinence, and it's a type of incontinence where sudden increased there will be incontinence because of sudden increased intra-abdominal pressure, like coughing, sneezing, etc. So options for you are, the first option is overflow incontinence, second option is reflex incontinence, third option is stress incontinence, and the final option is urge incontinence. So what is the answer? Involuntary loss of urine due to sudden increase in intra-abdominal pressure. So what is the answer? So here the answer for the question is option number C, that is stress incontinence. Okay, stress incontinence. So we will see all these incontinences in brief. So stress incontinence, it is an involuntary loss of small amount of urine due to the sudden increased intra-abdominal pressure, such as with coughing or sneezing. Okay, sometimes patient may complain like, when I cough a lot, when I sneeze, there will be sudden involuntary loss of urine. Okay, so that is known as the stress incontinence. Then what about overflow incontinence? So overflow incontinence occurs when the bladder is over distended and it reaches its limits of compliance. Okay, so there is a limit for the bladder to extend and hold the urine. When it extended over that limit, the intravesical pressure exceeds the resting urethral closure pressure and urine overflows despite the absence of detrusor contraction. So you know the normal physiology. So whenever there are the stretch receptors are increased, in the stretch receptors are stimulated, then the detrusor muscle, that is the muscles that cover the bladder, it will get contract and the urethra will be opened and the urine will be emptied. But here what is in the overflow incontinence, what is happening is the bladder is already over distended because of the urine and the compliance have crossed. So there will be pressure is increased, and without the detrusor contraction, the urine will overflow. That's known as the overflow incontinence. Then another one was the reflex incontinence. So reflex incontinence is due to the neurological impairment of the central nervous system. So this is a central incontinence, and common neurological disorders associated with the reflex incontinence are stroke, Parkinson's disease, brain tumors, etc. So this is because of the nervous innervations and their problems. Okay, so that is the central incontinence or the reflex incontinence. The last one is the urge incontinence. So what is urge incontinence? So it is a sudden intense urge to urinate followed by an involuntary loss of urine. Okay, so already there will be involuntary loss of urine and there will be sudden intense urge to urinate. So people who experience this urge incontinence get a strong feeling to urinate even when the bladder is not full. Okay, so even though the bladder is not full, they will have a feel to a sudden urge to pass urine, and there will be a involuntary loss of urine also will be there. So that is known as the urge incontinence. Okay, so with this question I think you are getting information regarding the reflex incontinence, urge incontinence, stress incontinence, and the question already we have explained. So with this we are coming to the end of this session, and I thank everyone who watched the video till the end, and once again I request everyone to share about this platform to others and make use of it, because our exams are coming. So once again thank you all, and stay tuned for the next video to come. So we will come up with another video very shortly. Till that time, bye.